Welcome to our first ever episode of the PCHD EMS podcast. My name is Jeff McNew. I'm here with our medical director, Dr. Northeim. And from JPS, the Level 1 Trauma Center in Fort Worth, Texas, we have a special guest today, Dr. Ghandi. Dr. Ghandi, tell us a little bit about yourself.
Sure. I'm Ghandi. I work for Acclaim Physician Group, which is under the JPS HealthNet umbrella. And I'm the trauma medical director at John Peter Smith, which is our regional government hospital for Tarrant County. And I've been there over 15 years. So JPS was a level 2 trauma center when I arrived in 2007. And so my charge was to make it a level 1. And so we finished that and became officially verified by the American College of Surgeons and designated by the state of Texas January of 2010.
Well, that is quite an accomplishment. Thank you very much for joining us. And before I introduce our medical director, I'd like to introduce PCHD EMS. We cover an area of 910 square miles west of Fort Worth, centered around Weatherford, Texas. We have 6 stations, 11 ambulances, and 3 rapid response vehicles. We have blood, pericardicentesis, finger thoracostomy, and ultrasound, thanks to Dr. Northeim. Also, thanks to Dr. Northeim and Best EMS, we have aggressive new protocols and are doing a lot of training with our fire departments. Dr. Northeim, tell us about yourself.
Yeah, so I've been involved in EMS since I was 15, actually for a service called Life Care back in Cleveland area. Been involved in EMS and the dispatch front and as well as an EMT, and then running 911 calls and flight programs. And I'm an ER physician at Baylor Scott and White and Grapevine and also McKinney. But I'm one of the best EMS med control directors. So we have over 35 agencies in Texas. And so we've been doing a lot of work over the last 8 years trying to continue evidence-based protocols and hopefully make people better. So we've been here less than a year. Dr. Bertrand's my associate director. And so we've been adding more critical skills, which we're able to do because we have Tahoe concepts, we have critical care paramedics, we have sedation drips. We just added blood to the protocol as well. Dr. Ghandi's helped out a lot with that, and we're really trying to push the whole blood program as well within the RAC. So it's been an exciting time. I think we've learned a lot together, and we continue to push the envelope. And so this was the next thing that I thought we probably should do to try to educate others.
Yeah, absolutely. And we've had blood for roughly a month, right? And we've given it 3 times already. Seen some pretty good results with at least one patient that made a difference. So
yeah, I think the thing we learned was that we actually gave blood twice for a medical reason, for GI bleed, which everyone thinks with it that we should be doing for trauma. We get once for trauma, but GI bleeds are another big player for us out here, especially being as far from the hospital as we are.
Yeah. So part of our aggressive protocol is part of the paradigm shift that's been out here is actually these checklists. Let's go over that real quick before we get into the rest of everything.
Yeah, so we're a lighthouse community for Resuscitation Academy. So we were able to go to Seattle a few years ago and we brought back a lot of their techniques and then we added on to them. And I think one of the things we learned is that every good system needs a checklist. Pilots use checklists in order to cover everything. And so we came up with a checklist very similar to Seattle that shows kind of our pit crew positioning, a description of each of the positions and what they're supposed to do. So at 3 a.m, if someone were to forget, or we want to make sure that everyone's doing what they're supposed to do, and we don't want to forget to hook the O2, the BVM up to the O2 bottle, or forget the capnography, or potentially forget something that may help our patients survive, that we'll have a checklist. And so we actually, when we came back from Resuscitation Academy, we had all of our agencies get together and send leadership, and we developed a checklist together. So it was a joint effort. And on top of there, our medical termination of efforts is in there. So if anyone forgets, they can grab the checklist, and we kind of store it in our the pocket where our pads are and our monitor, so it's easily accessible. No one's grabbing a protocol book out, so it looks very professional when they do it. And then when we got back, we realized that we probably needed to hit the trauma arrest piece, and that's what we'll talk more about today. Is we are very good at getting on the chest right away on medical cardiac arrest, and should that be the priority on a trauma arrest? Should we be focusing on that, or should we be focusing our skills, ruling out our H's and T's, and doing something about it? So We actually added a quick flow pathway based on blunt. We did based on penetrating the head, and then we did penetrating the body, because I think each of those three are very different. And so that's kind of where the checklist came from. But we may talk about this today, and 2 months from now, is when you have the big trauma in the middle of the night or when you're not expecting it. So just to be able to pull this out or have someone on scene, whether it's a first responder, throw it out, a supervisor, someone to grab it and say, hey, let's all get on the same page on this call. And, I've seen on several calls with writing out very much focused on tibial IOs with low flow rates and giving ACLS drugs and trauma rests and on the chest. And you have an agency that has ultrasound capability, finger thoracostomy capability, needle decompressions not being completed. We'll even see people come to the ER with blunt trauma and a lot of the procedures not being done. And so that's why I thought we need to focus more on it. And I think it's a good educational piece for everyone throughout the country.
Yep.
So I agree with everything, and especially I love the checklist. And I had gone through that just before with you. I think it's spot on to have that. And you and I have spoken before that really the advances in trauma care are not going to be in hospital. It's going to be pre-hospital, because we all know that about a third of the patients die at the scene. And why do they die? They die from head injury, they die from torso injury. And in the torso, there's two big things: bleeding and then pneumothorax or other issues like that. So getting on that chest early on is huge. And I think that's very important. And then we'll talk about, do we need to be doing the CPR part or not in trauma? And if you look at the literature, there's lots of different papers out there, but none of them are prospective, randomized, double-blinded trials. And so there's a tendency to not have great outcomes even with CPR. And by that, I mean, you do CPR, you get resuscitation, you get a return of spontaneous circulation, now what?
Right.
And then either the patient goes on to anoxia or they, are devastated neurologically. Both are horrible outcomes. And so then what have you done?
Right, and I think the way that I kind of think about it is, if you had a blunt trauma patient who was exsanguinating somewhere and you're doing compressions, in my mind, you're probably encouraging them to bleed out faster. So in my mind, until you get volume status, addressing airway, addressing the chest, to me, that seems to make sense. Obviously, blunt trauma has much higher chance of death than a penetrating injury. And penetrating injury, you really know where the injury's at. On blunt, we're always kind of guessing as to, where that injury is. But that's kind of what we focused on. And, I think the checklists do help us to kind of stay on task, because I think it's a very different patient than medical. And then we really throw in there, what about the patient who potentially has a medical event and drives off the road and crashes, right? Which event caused that? And so the crews are going to have to kind of think about, does the patient have any signs of trauma? Do we think this was medical first? Do we think it was a traumatic event? But what I was seeing was people that were falling 40 and 50 feet that we clearly knew was trauma, or someone that jumped out in front of a car that we really knew was a traumatic event, and really giving a lot of epi and giving, compressions, and then getting to the hospital and, the tension pneumo wasn't addressed, right? The airway wasn't addressed sufficiently. We didn't think about potentially throwing a pelvic binder on a patient. And what I tell my crews is, pelvic binder is really not going to hurt anybody. I mean, if you're unsure, let's throw it on until we get the X-ray at the hospital. So that's kind of what we've taught here. But stopping the bleeding first is obviously the most important thing, and then addressing the rest. But, the other thing is that I hear a lot from crews when we look at trauma patients, especially traumatic injuries to the head, penetrating to the head, is, we used to learn in medic school, and probably, the people who have been in EMS for a long time, is they have brain matter, so they're dead, right? And so that's true, but I think we've come a long way with organ donation. I think crews understanding, that an organ donation patient has to have a pulse back, right? Or we can do tissue donation after someone's passed away, but true organ donation, we have to get that cardiac, we have to get the cardiac piece back. And so, there's pseudo PEA, which I think a lot of agencies have been kind of slow to educate on, but if you have a PEA patient and you stick an ultrasound probe and they don't have heart motion, that's a much different patient than sticking an ultrasound probe having heart motion. You just can't feel a pulse. I mean, they're so hypotensive. So in my mind, you would treat those patients totally different. So kind of our general rule is if you have a trauma patient who is pulseless and apneic and asystolic, we're done. We don't work those patients. We don't try to revive those patients. If you have a pulseless and apneic patient who has any rhythm but asystole, we're going to start getting to work. And if it's a blunt, we have the option to work them for 10 minutes, do our skills and call it. If it's a penetrating to the head, same thing. We work them for 10 minutes. We have the ability to call it after 10 minutes if we don't have ROSC. But the penetrating to anywhere but the head, we're going to try to get going quickly, do a lot in route, and try to get them to a trauma facility as quickly as we can.
So on that note, and just kind of curious as to what you guys do over at JPS as well, we don't give blood if they're in cardiac arrest. I feel like that would be a waste of resources, a waste of blood. Once they get back, once we get pulses back, obviously that's when we would consider, giving blood to a traumatic arrest. How aggressive do you guys get with blood when you have a trauma arrest roll in?
Yeah, that's a great question. So it all depends on what you have. Similar to what you're doing in the field, we're going to do an ultrasound and see, okay, what's going on. And if we're not getting anything and the patient has no signs of life and they've had CPR for 15 or more minutes or have been, without CPR, without anything for 15 or more minutes, then we're probably going to stop. And then we don't do anything. If we have cardiac activity, we're going to get to business, right? As you said, we'll do bilateral finger thoracostomies, and then again, see what else is going on. And then what does the patient need at the time? So over the last 10 years, we've had 14 patients that have gone on to resuscitation and been organ donors. And so you say, well, it's only 14 people, but 14 times 4, now you're talking 56 people that are alive because of those people or more.
So they're donating, what organs are they donating?
So it all depends. So typically we'll get kidneys, liver, lungs, heart. We actually have gotten several hearts even after a cardiac arrest,
Wow.
Believe it or not. But certainly those are great to be able to get all the organs that they get.
Life-changing, yeah.
Yeah. And I think we did have one pancreatic transplant, and I think that was it.
Yeah, so I think if you think about something that, say a gunshot wound to the head, that's self-inflicted, and obviously the family, the grieving. But if you could take it a step further and say, yes, it's a horrible event, but, instead of just calling it on scene and we did get a heartbeat back, right? Who's that patient helping down the road? Can the family maybe rest a little bit easier knowing that their loved one did help somebody else? And so that's why I encourage EMS in the field, not just to use the brain matter, but to think about, hey, listen, let's look at pseudo PEA. Maybe they're just so hypotensive that maybe if we could, pack the wound, maybe if we could give some volume, maybe try to get the patient back from a cardiac perspective, that you may have a fairly young individual with lots of potential to donate. And I think we've seen that several times that, let's take the extra time. And of course, on the CPR thing, we're just saying, let's focus on your skills first. I think the data on CPR is back and forth, but if you're going to transport after you get all your procedures done, I think it's fine to do compressions. Obviously, I think it's fine to do compressions on somebody with a isolated, penetrating to the head. But our point is, let's not get into the ER and not do all of our H's and T rule out procedures, but let's just do compressions, right? So let's do the compressions after we've tried those things. And that's kind of our big push. And I think that's working well at our facilities and our agencies.
It's definitely been a real culture shock for us because, we're used to, if we're going to transport somebody like that, just throwing them in the ambulance and going quickly. But now we're getting to the point where it's like, okay, let's get some stuff knocked out. Let's spend 10 minutes here and really, really hopefully give this patient a chance. And something I remember you saying recently about, penetrating trauma to the head. If you're doing CPR and you're pushing brain matter and blood out of their head, stop that from happening first. Wrap it up, do something to keep their blood volume in their body. And then you can do CPR, but don't push the the fluid and brain matter out. So
Exactly. I think that's something across EMS that we're doing a better job is staying on scene, working that patient. I think the ones, I mean, correct me if I'm wrong, but the ones I think we really need to get going on to the penetrating to the body. I mean, where we know where the injury's at, where we can get them to an ED, where we could potentially do a thoracotomy, get them to the OR. I think those are the patients that we probably need to load and go and do most of the procedures en route. But the isolated of the heads and until we really get a pulse back, the blunts until we really get a pulse back. I mean, I think we're fine to stay on scene.
Yeah, I think you had said about 10 minutes. I think that's a reasonable time frame. And for us, when we get the patients who have gunshot to the heads for whatever reason, we do the same kind of thing. If they have cardiac activity, we'll resuscitate. So at that time, we'll give blood, FFP, and see where we're at. And, if we're not getting anywhere, then we will stop, right? We have limitations. So blood is a very valuable resource and scarce resource for us. And so we want to be good stewards of our blood resource. So we're not, giving 100 units of blood.
absolutely.
A regional bank has 1,000 units of blood available. So,
Right.
With our deployment of blood on our Tahoes, we've actually started a partnership with Carter Blood Care. We have a sponsor code, and a lot of our employees have started, donating. And I think we're going to actually, pass or go over the amount of blood that we're carrying that's provided just by our employees. So it's been really cool. We may not see our actual units of blood on our ambulances or on our Tahoes, but we actually have the ability to give the blood that we're giving, kind of. And I think it's been pretty cool because it is a scarce resource. But when you get people involved in their own communities, there's so much more buy-in, because it's like, I'm giving blood that my neighbor or this guy down the street, if he gets hit by a car, has a GI bleed, could also get and could save somebody's life that I actually know. It's people are more likely to give if they have buy-in.
yeah, no, absolutely. That's a great point. And certainly we had a meeting with Carter yesterday to talk about whole blood and kind of, as we talked about the evolutionary process. And so I think there are more, and some of their concerns about leukodepleted whole blood and all of that. So we showed them some more data. And so we'll let them take a look at it, and then we'll push it again. So, we've talked, where do we want to get to? Well, we already know in our minds where we want to get to down the line. It's just, what does that process looks like? What does that evolution look like? And obviously we're not going to wait hundreds of years. We're going to kind of keep pushing and keep pushing and keep pushing. But certainly that effect, as you just put out very nicely, is huge to get buy-in from the blood banks.
Yeah.
And that was one of the things. Now, actually, the director for Carter actually said that very thing in our meeting.
Yeah, I think the thing was with COVID, I mean, they had depletion of blood. It was hard to get blood. And so I think their point was, hey, we don't have a bunch of units just sitting on, EMS units or fire units throughout the state. And I think what we've showed them is that, our donation ability across the first responder entity, across, the county, across the city, can be fairly strong. And those are maybe people that wouldn't have donated otherwise, but they know that they're supporting their agency, they're supporting their county and their city. And so I think that's something that Carter's realized will be very beneficial for them.
Yeah, I hope so. And obviously you're talking about getting to low titer whole blood, correct?
Right.
Yeah.
So that's what we're using now. And so we had a symposium a week ago Friday, so October 28th, and we had a speaker from Houston, Brian Cotton. So Brian's a trauma surgeon down there. He's very much into the blood resuscitation. And he's one of two people in the country that are true super experts. And so he went through all the data about, do we need to do, low titer? Can we do regular or high? And actually, it's almost like there's a benefit if you do the high titer. So showing that to them makes it so that there may be more accessibility to whole blood rather than just wait for that specific type. And then we also talked about, well, what about O positive versus O negative, right? Because normally we want O negative so we can just give it to anybody. But how about O positive? Can we do that? Well, you can. You can give it to men. You can give it to women over 50, 55 years of age who aren't going to be having babies. And even if you give it to a young person that's a woman, and if they're pregnant, you can go ahead and give the Rogaine.
Right.
So you have options depending on what you have available. Right. So I think that's really important.
Yeah, I think it's kind of like sticking your foot in the water. We got to stick our foot in the water and explore it and get more data. I mean, I think that's something that our RAC is doing and we're doing as facilities is really just trying to get more data. You know, how many agencies would be willing to spend the money to carry it? It's a big deal because it costs money to carry it. You know, how many agencies have something set up where they could potentially put it on a squad concept, right? And so if you have a city with 8 or 9 ambulances, it's probably not going to be cost effective to do that, right? Mm-hmm. But if you had a squad concept, Tahoe concept, it becomes a little more cost effective to do that. Obviously, the longer your transport time, you know, I think the better it's going to be for the patient. And then, you know, there are a lot of the air medicals that carry it. And we, you know, out here, if we have weather, we have a lot longer time with our patients taking care of somebody who's, you know, potentially hypovolemic than even the air people would, right? Yeah. So there's a benefit to our patients to carry it. So more to come on that. We'll probably have a separate episode on that. But we have gone down that road.
We've talked about kind of the general stuff. What specific treatments do you guys typically do if EMS is really just, you know, throwing somebody on the stretcher, brought them in, and then, you know, hopefully you're within 10 minutes of the patient actually going into at rest? What does the first, you know, 10 minutes in your ER look like for somebody that's had a blunt trauma arrest?
Yeah, so great question. So we're actually looking at good, bad, or ugly. And if it's ugly, do they need to go to the operating room or do they need to stay in the trauma bay? And if they need to go to the operating room, we go straight there because we have everything there, right? We have anesthesia who can intubate. We have other people who can get big lines in. That's as a surgeon, that's kind of my happy place, right? I've got everything there. I know it's a safe place. I got light. I got plenty of resources. I've got several nurses. I've got a scrub tech. We have anesthesia taking care of the head. And so you have all of these other resources. And it's not to say our emergency medicine physicians are not good. No, they're awesome. You know, they can intubate and under circumstances that maybe an anesthesiologist cannot. However, we're looking at stopping the bleeding. And I can't do that in the trauma bay. Right. So that's kind of the first thing. And that happens in the first 2 minutes, right, give or take. And if it does, then I pick up the phone and I say, hi, this is Ghandi. I need to take this patient to the operating room now. What OR am I going to go to? And they'll say OR 9. And then I go straight up to OR 9. And we took that little trip. And, you know, it's not that far.
No, it's quick.
But by the time we get to the operating room, they're ready. Anesthesia is ready. The nurses are ready. The equipment is ready. So let's say if it's kind of bad, right? Then we'll see, okay, do they need a little resuscitation before we intubate them, or do they need to be intubated? What's going on? And certainly if you've got a patient who's flailing around, you have absolutely no control, guess what? You're going to have to get control. Yeah. If you don't have IV access, then you may give them IM ketamine, 200 milligrams. That'll bring them down. And then intubate and do whatever else or get IV access and then go from there. So I think it always depends on that patient and what we think is going on.
And I think that's been a big push across our system, especially out here, is we're trying to fill the tank before intubating as well, right? I mean, I think there's a lot of incidents probably in the past of, you know, peri-intubation arrest, especially in someone who's hypotensive. And you think about somebody who's got a pressure of 70, if you stick a laryngoscope blade in their mouth, what's going to happen to their pressure? They're going to vagal down. Probably going to lose it. You're not going to feel it, obviously. It could be those pseudo PEA patients we're talking about. So I think we've pushed really across our system is, you know, fill the tank. If you need a little push dose pressure, give blood, give volume. You know, think about not going tibial on the IOs if you're going to go tibial. I mean, let's go distal femur. Let's go, you know, proximal humeral. We've made a big push on that. Tibial is really our last resort now. But, you know, let's give 5 liter per hour access versus 1 liter per hour in the tibial. Let's have the ability to give our meds, to give our RSI drugs if we need to. But I think, you know, just like trying to get a patient oxygenated for us over 94% before we hit the paralytic, let's also try to build our blood pressure up. Let's equilibrate the patient as best we can. Maybe throw the pelvic binder on, right? Maybe give a dose of TXA, all this stuff together to try to get the patient so we can have success and the patient doesn't code. And we've probably seen that a lot in the ER. We've seen that a lot with EMS where they go to the airway without waiting and that patient codes. So
yeah, and the AAST, so American Association for the Surgery of Trauma, just put out a publication that basically says exactly that. And I believe that the next version of the American Advanced Trauma Life Support course will have that you actually do cardiac, meaning make sure you have a blood pressure before airway for that very reason.
Right. So I want to touch on something you said, because I think it's something that EMS really struggles with. I know I've been in the same boat before. You said if you don't have control of the patient, you have to do that before you do anything else. Before you take somebody to the OR, you're going to RSI them. I think that we have this urge that's just like, if we could just get to the hospital doors, they're going to be okay. You know what I mean? Like if we could just get them in front of you, they're going to be okay. And so sometimes EMS crews forego intubating, like, hey, you know what? Yeah, he's combative. Yeah, he's, had a head injury, obviously is going to be intubated as soon as we get to the hospital, but let's just get him there so he doesn't die. And if that's something that we're able to do without killing them, if they have the blood pressure at that time to sustain it, that's probably the perfect time to do it, as opposed to, we wait 20 minutes, or for us, our average transport time to Fort Worth is 34 minutes. So if we wait 34 minutes, somebody who has a belly bleed and is combative is not going to have a normal blood pressure by the time you see them. And so you're going to have to be, doing all of this stuff before you even get an airway. We need to be doing that before we get to you. And we really tried to push that.
Yeah, I think the two big studies each had 10,000 patients that were done pre-hospital for intubation, showed that, the outcomes were better with intubation in the emergency department versus pre-hospital. The problem with those studies is if you look at the time frame, it was short, right? Because it was mostly big city style.
urban environment.
Yeah. And so what you say is very true. You're in a little bit different situation because 34 minutes is more than half of that first golden hour, right? And so, a lot of it has to do with what you have. And so what do you have? And what do you need to do to keep that patient alive before getting to us?
Yeah, and I would also argue some of the studies on intubation by EMS, I think it really depends on, your first pass rates. I think it depends on any complications you may have. I mean, there's certainly agencies who are a lot better first pass than others. There's certain that have, certain agencies who have a higher, complication rate, maybe peri-intubation arrest, higher percentage. So, I think that depends, and I don't know how you look at that, because I've seen those studies, but then I also think, wow, if that patient comes to me, the first thing we're going to do is we're going to intubate the patient, right? And so if you feel comfortable with your service and you feel comfortable with their skill set, it seems like that's probably a better thing to do if we're going to do it when they get there anyway, right?
Yeah,
so it's very dependent on, I think, on the agency.
Yeah, your point is spot on. And I think those studies need to be repeated, because if you read it, to me, it was a bias going in. Like when I read the intro and the background, I was like, I know what this is going to say. I bet if those studies are repeated now, the outcomes will be different. Yeah. And especially if it's larger than or greater than a 10-minute time frame to transport.
Depending on, if you're a high-functioning, RSI type.
A couple of our clinical supervisors have been teaching an airway class here over the last few years. We actually are going to put it out kind of in podcast form. But we've seen our numbers go up. We're at 94% first pass success rate right now. We have video laryngoscopes. Depending on the situation, if you can do it safely, you may not even need to pull over to do an intubation. I know we've done that several times where, we have the interstate. It's fairly smooth. If you're able to, sit safely in the captain's chair, you can perform an intubation with two providers in the back fairly easily while you're going down the road. So there's virtually no delay. And I
think your overall rates are 100%, right? So
Exactly.
Those are tremendous numbers. And if we are doing CPR on a medical cardiac arrest, we're not stopping compressions to do it, right? So it makes the airway tougher, but it's better for the patient. So that's another thing that obviously we stress. We're not, we're doing medical and intubating, we're not stopping. So.
Well, and technology is huge, right? You mentioned the glide scope. That was not there when these studies were done.
Right.
Yeah. So, if you had that, if you had all this training and everything else that's happened after those two studies came out, I think you'd have a very different outcome in studies if we were to do it now.
From here, we start talking about EMS's use of ultrasound, doing fast exams, and activating the OR from the field.
Yeah, I think the important part too is, say an agency brings you a blunt trauma patient and they've already darted or bilateral fingers are done, maybe they've done a pericardial, fits their protocols, they have an airway established, they've given volume. What's the first thing we're going to do in the ER? Maybe we're going to stick an ultrasound probe, and if there's no heart motion, we're gonna be done. So I think that's important for people to note. I think ultrasound is a huge piece of what we do on a daily basis. I think it's a huge part for EMS. I think if you trust the agency and you trust their skill, and we know they're going to be taken care of, and probably their tank is going to be filled, and we have procedures done, and we have airway intact, and the patient's sedated. That's an easy patient. That's like it's like going right to the OR, just like going to the cath lab, right?
Yeah, so, that's exactly right.
But you have to have that trust with your agency, make sure that the training is there. So.
Yep. And whether that scan, and the only reason for the scan, what I'd like to do is get to exactly where you're getting at, is the paramedic is calling and saying, hey, this guy is not just a level of trauma, but he's a level 1 trauma OR, which means we'll just go straight to the operator. There are a few centers across the country that actually have an operating room in the emergency department. And so they would go right into that room. And we don't, but as you saw, our OR is not far. We go pretty quick up there. So, but I think it can be a number of different ways. But once you get that and we know, and you say, this is a level 1 OR, blood pressure is 70, fluid in the right upper quadrant, left upper quadrant, whatever. After, in the rest of the history, we know, okay, yeah, we're going to be lapping them. So let's get going. So, and, the other aspect of that is it's really important. If we go to the operating room and lap them, we can get their blood, we can cell save it, give it back to them. So there's a lot of different processes that can be kind of put in force because we have that pre-hospital thought process and real verification of that bleeding.
Well, plus you'll have time. I mean, if we could do that from a county level, you're going to have 30 minutes to get ready.
Yeah.
And your OR team's going to be ready, and so everyone's going to be ready to go. So just like we know with stroke patients and with STEMI patients, the quicker we can activate those patients, get the CT table cleared, get the cath team in, all those things make a big difference with patient survivability and outcome.
I think, talking about ultrasound as well, I can't tell you how many times I've worked on somebody that I knew wasn't going to make it, but I had no tool to tell me, like, definitively, this person is, my protocol said, hey, you got to work this. I didn't have that sono to be like, look, there's no cardiac motion. We've been doing this for, we've given 27 epis, like, they're not making it. We spend an hour, blood, sweat, and tears, get to the hospital. You guys pull out an ultrasound, time of death. That is just, that is such a defeating feeling. It's like, if we just had that tool, we could have saved the family a transport bill. We could have saved, an ambulance from being out of service for 2 hours.
Just the safety of the crew.
Absolutely.
You think about these patients, and we talked more about that in another podcast, but why are we necessarily taking, medical arrest without a pulse, to the hospital, lights and sirens? We have a Lucas device, right? We have, most of us have vents. Do we really need to save that extra 3 minutes with someone who doesn't have a pulse, right? And so the safety of the crew is important too. To have that tool, the ultrasound, and it's just going to take reps to get to the point that will be part of our termination criteria. And just to be clear, we don't get 27 epis. We maxed out at 3 for medical. But,
that was historical.
But very good point. Very good point. But if anyone wants, copies of our checklist, we're happy to share that. So you can contact us via social media or Parker County Hospital District or Best EMS.
I just got a whole bunch of them ordered, so we're about to hand out.
It's great for your first responding
food.
entities as well. So if you work with the fire department, it's a great piece to have. But I think it's not very much fun to get on a case and have to pull out your protocol book during a critical case. So this kind of adds a little more professional nature to it. Seattle gave us the idea, and we kind of took it and ran and added even our ECMO criteria in there as well, because it's kind of hard to remember that when everything's going down as well. But it's a great tool to have to kind of
Absolutely
give you a little crutch when you forget what we just talked about.
Not only that, but we all have our phones now, and we've got protocols on our phones. But I actually think this looks a lot more professional.
Well, thanks, Dr. Ghandi. It's always
Thank
great to have you.
you. Good to
Appreciate
see
it.
you, Dr. Northeim.
Thanks, Jeff.
Thank you.
Jeff,
Thank you guys
thank
for
you.
being on. Hopefully we have you back, and we're gonna have a lot more episodes. So definitely stay tuned. This has been an episode of the PCHD EMS podcast. Thank you for joining us.